this is going to change the trajectory of what we have for patients with CML. There were really two moments, and the first was in the laboratory when I got some compounds from Novartis. They were blinded. I didn't know what they were. I actually didn't know how to set up these experiments because I'd never done anything like this before. But I set up this dilution curve of these compounds against CML cells and normal cells. And there was one compound that stood out. It killed the leukemia cells and didn't kill the normal cells. And as I expanded that, it was even more dramatic in over about 1,000-fold dose range. And it was, wow, this is doing exactly what I hoped it would do. And there was a day in clinic where 3 patients in a row came in. Months earlier, they had been told, get your affairs in order. There's nothing left to do. And all of a sudden, their blood counts are normal for the first time in years. They're feeling great. And they told me about how this burden had been lifted from them, how they now had restored hope for the future. And it was just amazing. So if patients were on board, I needed to get on board and realize this is going to change the trajectory of what we have for patients with CML. Even if it only gave them a few more months, it was giving them incredible quality, and it was restoring their hope for the future. And some of those patients are still with me 25 years later. The biggest impact is be able to go to clinic, newly diagnosed patient, and tell them, we expect you're going to live a normal lifespan. Here's what it's going to take to get there, and it's going to take some work, and you'll have to take some medication, and maybe for the rest of your life. But this is quite different than it was when we started out 25 years ago. That's a huge impact.
Because I was in biotechnology, I happened to have gone to the Leukemia and Lymphoma Society's annual ball in DC in 2001. And at that ball, the current head of Health and Human Services announced a new drug called Gleevec was going to be approved. 2 years later, I had my regular physical, had blood drawn, went back to my office. My doctor called me. I went back to his office. He drew my blood again, and my white blood cells were abnormally high. And actually, we both looked under the microscope, and the cells were abnormal. So I had CML. I mean, TKIs is sort of the first targeted medication to be approved, and it's made a complete difference. It's taken a disease that had an 85% fatality rate after 5 years into a chronic disease that, if it's properly managed, has a 97, 98% survival forever.
We had patients of CML dark because of busulfan toxicity, tummies full of spleen, like spleen 20 centimeters, 30 centimeters, cacaxic, just lying in bed waiting to die. And then you had this magic bullet, and in 3 weeks' time, the patient was standing, sitting, eating, and walking. So, medical oncologists of my generation, hematologists of my generation witnessed that magic, that transformation which imatinib brought about in the treatment of CML.
I remember that it's a funny story because the first development of TKI, of imatinib, was in 1998, 1999, but at that time I was pregnant. My son was born at the end of 2000, and I didn't went to the ASH meeting where the results were presented, but everybody was talking about it, and soon, 1 year later, TKI was approved for CML, and I always joke that my older son was born together with imatinib. And so it's 25 years now. He's turning 25, And all these years, I could see all the evolution that the patients, all that we have accomplished in treating CML patients. There was a patient that was pregnant together with me at the time. And then in 25 years, I raised my family, and she also raised her family. And now she's in TFR for more than 5 years. So I think that's what we want for our patients, that they can have a life just like the normal population, just like us.
I remember the very first patient who became molecularly undetectable in my clinic. And immediately I thought, wow, I think we might be able to cure some of these patients if they can get to undetectable. But it was really hard to convince people to stop therapy because, again, they'd been told you got 3 to 5 years to live, you've run out of options, and now you're on this medication that's saving your life. Would you consider stopping? It's like, no, I'm not going to stop it. Fortunately, Francois Mahone in France was able to initiate a study where he stopped some patients who were molecularly undetectable, and half of them were able to stop therapy. And that launched the entire prospect that some patients could be cured. What's interesting to me is that 50% of people who get to undetectable can stop and 50% can't. And we don't have really good predictive abilities for who's who. And we only get about 20% of patients to that status. So to me, there are two huge unanswered questions. How do you get more patients to undetectable? And how do you predict who can stop and who can't?
2 out of 10 patients, they have access to advanced treatment. And we have to find ways and means to subsidize these treatments. There's nothing more frustrating than knowing that a treatment is available for that particular patient in your country, and you cannot give that treatment to that patient because of economic reasons.
I'm grateful for organizations like the Max Foundation, which is working incredibly hard to provide access in low and middle income countries. And again, this is a global problem. We need to think about drug pricing in a way that allows drug companies to thrive and survive, because that's where drugs are made. We need to make sure that they're profitable, but we also need to make sure they're accessible. And that has to be a global conversation. It can't be a conversation in isolation, because ultimately we want everybody to have access to medications that they need to save their lives. And I mentioned the 1999 conference in Biarritz, where many of the founders of ICMLF and others came together. And you have to realize I was a pretty young investigator at the time. And I was working now with the giants of the CML field, the John Goldmans, the Rudiger Hellman, Francois Guillot in France, and just all the giants in CML. And they embraced me. And they looked at this is going to be a huge advance. This is somebody we want to make sure that he gets the credit he deserves in bringing this treatment forward. And I just felt so welcomed by the CML community. And to me, that has been the remarkable thing about the ICMLF, is that it's these incredible experts in CML around the world coming together to benefit patients. And that's the same warmth that this community has. And that's one of the things that I so enjoy about this organization, is that it's the world's experts trying to get knowledge out around the world, and to make sure that patients everywhere get the same care that they can get in the United States, in France, Germany, the United Kingdom, Australia, everywhere. And that's what I love about working with this foundation.
All I can say is that, TKIs has certainly been a miracle drug. And, 22 years after being diagnosed, nobody knows I have CML. And for most of those 22 years, nobody did know I had CML.
One of the very first children who was enrolled on a phase 1 trial for kids, she was 11 years old. She's now married, 2 children, off therapy for over 5 years. What a remarkable reward.
Again, the 25 years, I think we should celebrate that, because it was a game changer for the life of many, many CML patients. And we still have challenges. Some patients may be resistant still, but I think we are going toward the right direction with the new therapies and the new developments.